Hello, good morning, good afternoon, and good evening. We have some participants with us from all over the world. We thank you for joining. Today is the third in our series of the PlanMecca Digital Mastery webinar series. And with us today is Dr. Jay Burton from Nashville, Tennessee. His topic today is 3D digital orthodontics, how 3D changes everything. Before we get started, I do have a few housekeeping items. First, my name is Jody Rodney, and I am the Vice President of Marketing and Education for PlanMecca USA. We're thrilled to be hosting this series and hope that you all take away something from today's webinar. First, everybody will be muted by our host. All technical issues, if you have any, should be submitted through the chat function. If you have questions for Dr. Burton, please submit them via the Q&A function. At the end of the presentation, we will open it up to Q&A. We anticipate Dr. Burton's portion to take approximately 50 to 60 minutes, and then we'll open it up to questions. We are recording the webinar, and it will be available on the registration page where the registration link was for the webinar. At the end, there will be a post-webinar CE survey. The link will be submitted in the chat function. You must complete the survey to get the CE credit. Without further ado, I'd like to introduce Dr. Jay Burton. Jay, take it away.
Awesome. Thank you, Jody. I'm hoping everybody can hear me okay. Jody, can you nod your head if my audio is coming through? Okay, perfect. Awesome. Let's go here. So big thank you to PlanMecca making our days not quite as long and boring by giving us a little bit of dentistry and orthodontics to talk about, because I know if you're like me, if you go too long without talking about dentistry and orthodontics, you kind of go stir crazy. So this gives us an opportunity to at least stay somewhat engaged in our profession. So the title of today's webinar is 3D technology or 3D digital orthodontics and how 3D technology changes everything. Let's see if I can get this to work. Hang on one sec. There we go. So, few disclosures and background information. I am a diplomate of the American Board of Orthodontics, a member of all of the normal associations, key opinion leader for PlanMecca on the advisory board for OrthoScience and Form Labs. Prior to going to dental school and residency, I was an assistant professor of management and marketing. Went to dental school at Louisville, did residency at NYU, and then been in private practice for the last 6 years. Have 4 fish, 3 kids, 2 dogs, 1 lizard, and 1 wife. So lots of fun. And just as another disclosure, before I was a KOL for PlanMecca, well before actually, I purchased the Pro Max Mid. And it was after about 2 or 3 years of using it that I became a KOL. So I don't want you to think, if you're listening in, that essentially they gave me the mid and that's why I'm talking about how great it is. It's actually completely the opposite. I fell in love with it. It's a great machine, great image quality. You'll get to see some of the images that are produced. So when we talk about differentiation and 3D and orthodontics and just orthodontics as a profession, you can't help but find when you search anything orthodontic related, something associated with the DIY world. And I think we're faced with a situation where we've got to differentiate ourselves both from the DIY world as well as in general with regard to our practice. What makes us different? What makes us special about what we do and how we do it? And that's where I think 3D is so important. The benefits of 3D and orthodontics are huge and often ignored or forgotten about or just not talked about a lot. We'll also talk about how we can differentiate our practices using this technology, and then the importance of ultra low dose and then its value to orthodontics as a specialty. We'll also look at the importance of anatomy and how that takes preeminence over our historical norms and analysis that we're typically used to looking at. And then we'll talk about how 3D can help us continually improve both the profession and individually as a practitioner. And so a little bit about me and my practice philosophy. When I finished residency and got out, a very goal-oriented, objective-oriented person, you know, what did I want to do? What did I want to achieve in practice? And I had three goals. I wanted to provide the highest quality orthodontic treatment possible. I wanted to work with the most advanced technology. And I didn't only want to say that I offered certain procedures, I actually wanted to do those procedures. And so, yeah, that's kind of who I was. I kind of like to have goals. I like to have a focus and something to move towards. And so with that in mind, you know, take tons of CE, hopefully like this, and in an effort to improve and continually improve.
Hey, Jay.
Yes.
Sorry to interrupt. This is Jody. There is a little pencil palette that is coming up on your screen. I don't know. It's like, it's literally right on the right hand side of your screen in the middle. Yep, right there. I don't know if you can see it.
Oh, it's the video thing.
It's like literally a bunch of colored pencils.
Weird.
It is a little weird.
Okay, hang on one sec. Let me stop sharing real quick and see if I can get rid of that for you.
Okay, it's a color picker from the Mac.
Okay, yeah, that's helpful. Let's go to. Now let's hit play and back to screen share. Share screen, click here. Let's go back to here. Let's hit play.
Perfect. Thank you.
Awesome. Thank you.
Yep.
So this is a little video that Planmeca did to work with some of their sales teams so they can better understand the orthodontic process and just how it functions in an orthodontist office, how they might use 3D. So I've got a couple of videos that I want to show. So make sure you've got your sound on. I'm going to hope that sound comes through. So let's give this a try and see what happens.
Jay, I don't think the sound is coming through.
Sound is not coming through. Okay. Well, we're having all kinds of fun. Let's see here. Microphone. All right. Well, let's not worry about that video then. Long and short of the video is just what an average orthodontist time from the patient makes the phone call to the time that they end treatment in the office and they're in retention. So we're just kind of walking through the different stages of treatment so that we're all on the same page and kind of how I integrate 3D in that process. But for me, there's several benefits of 3D, and one of those benefits is patient education. And I didn't really think of this being a benefit when I purchased the machine. It was only after I had the ProMax Med in my office for several months that I started realizing, hey, it's so much easier to pull the 3D rendering of the patient up on the screen and explain treatment options or diagnostic information with them, having it in 3D. I mean, we live in a 3D world. We're used to interacting in 3D. And it was such a big difference between just showing them a 2D pan or a 2D set. So when I thought of benefits of 3D, it wasn't really one of them, but it has become one of my bigger ones. And then I would argue the biggest benefit of 3D is proper diagnostics and treatment planning. I find it very difficult when somebody shows me a pan and a ceph to truly treatment plan the case in what I would say is an accurate way. Because with 2D, you're losing what I would argue is the most important information that I have when I'm treatment planning, and that's the anatomy of the alveolar housing, because that's what really dictates the treatment options. It's what really determines the treatment plan for the patient, and that's where it really becomes more about anatomy and not so much about analysis and historical norms. So no longer are we treating to those norms, now we're treating to the patient's individual anatomy. It also allows you not to have to guess anymore. It lets you pick up potential 2D misses, supernumerary teeth, anatomical considerations, etc. And let's say that we got rid of the first 5, like we just totally made those disappear. The last 2, the fact that it's lower radiation than 2D and you have more information than 2D, in my mind, makes it a complete no-brainer. And it's what everybody should be practicing with, in my opinion, based on those 2 things alone. I can't imagine going or thinking about buying new X-ray equipment and only looking at 2D, or looking at 2D with only a limited field of view. The full field of view is, at least in my opinion, essential to diagnose and treatment plan accordingly. So huge benefits with regard to 3D. So let's look at a case real quick. This patient presented to my office a few years back, and I got the pan was sent over by the general dentist. And you know, if you look at this pan, there's not a whole lot that's remarkable. The biggest thing of note is it looks like the upper left central incisor has resorbed quite a bit. Okay, that's a little troublesome, but everything else, you know, condyles look good, you know, tooth counts good, no pathology noted, you know, so everything's looking for the most part pretty good. Here are the photos, and I know a lot of orthodontists that would have taken that pan, taken the diagnostic photos and the clinical exam, and been fine diagnosing and treating the case. Well, as part of her records, I took a limited field of view scan. I wanted to see what was going on with the alveolar housing. And this is the rendered pan from that. Again, not much that really just stands out other than that upper left central being a little bit short. But when we start looking at the individual slices of teeth and figuring out, okay, what's going on with the alveolar housing, where is the tooth in relation to the cortical plate on the buccal and the lingual, and where can't we move teeth? And we notice pretty quickly that there is little to no bone on the facial surfaces of these teeth on the lower. In addition to that, we see just how significant that root resorption is on that upper left central. So my colleagues out there that would have said, oh, you don't need a ceph, I'm fine treating with just a pan. Had you done so, you know, maybe you wouldn't have had the whole story. And maybe you would have flared the teeth out or moved the teeth into a position that would not have been ideal. But in addition to not having the cross sections, you would have missed the significant defect that was there as a result of active periodontal disease. Now, this is a case, as I mentioned, it was a DIY case gone bad, and the patient actually presented in the office and said, hey, you know, I've been doing the in-home aligner system from one of these companies, and you know, I'm just not happy with my bite. Well, okay, it's fine, you're not happy with your bite, but what I'm seeing here is a bigger issue. Essentially, the teeth have been moved into a position during the presence of periodontal disease, and essentially moving them outside of good, solid alveolar housing. And maybe somebody would have said back to me, oh, well, I have all my adults go through a periodontal screening prior to initiating treatment on them. Well, that's great, but why didn't the patient have that done with the at-home aligner company? And then in addition to that, even if they had that done, this patient was actually seeing a general dentist on a regular basis. And I don't know if they were just monitoring this or what, but it was a situation where they hadn't been referred to perio, or if they had been, they certainly did not go. I sent the patient to perio, and the periodontist basically did some deep scaling and root planing and said, okay, the patient's ready to go. And then I'm thinking back to the cross sections in the previous slide. I'm saying, oh, do I even want to move these teeth around? How much IPR am I going to have to do? And so on. And so then I took CBCT of the patient's initial aligners, and then I superimposed those over the patient's current CBCT to kind of see what treatment had been done and how the patient had been treating. And I superimposed these over the posterior teeth as best I could. And you can see that those lower incisors at the incisal edge has flared forward about 2.5 degrees. You can see that the PDL of that upper left central is widened, probably as a result of trauma. And you can see that in order to alleviate the crowding, what they really did was just procline and protrude those lower anterior teeth, which is why the patient comes in and says, my bite just doesn't feel right. Like, I need somebody to help me with this. In a case like this, maybe her best treatment option is to go backward in the tray. I know that sounds crazy, but maybe she's better off certainly from a stability standpoint, going back in time instead of staying currently where she is, which would be in traumatic occlusion. Granted, we could do some occlusoplasty, we could do some IPR to try to bring things back, but you can actually see the enamel wear on the lingual surface of the upper left central and how much that had worn as a result of her function, and then where that now, where she's now in MIP. So I'm going to skip this video because, well, y'all can't hear the sound. Here we go. Okay, so that was just one case showing how essentially without 3D, without CBCT, perhaps treatment would have been rendered and caused more harm than good. And I think it's important. So many are worried about the potential liability, concerned with, oh, what if I missed something? Well, what if you had missed that? What if you just went off the pan, said I didn't need a SEP, treated the case, and then the patient lost 1 or 2 teeth as a result of that? Are you not then liable for not taking a CBCT? And if I'm the expert witness that's called to testify, and there's a CBCT machine a mile down the road at a GP's office or an oral surgeon's office, and you didn't use that, then I would say you're liable for having technology available to you and not using it. But I think that the 3D technology can certainly be a differentiating factor and has been a differentiating factor in my practice. So throughout the slideshow, we'll have some interesting facts about Nashville just to keep us all on our toes. If you've never been to Nashville, it's home to the only exact replica of the Greek Parthenon. Pretty cool structure here in Nashville. So what are some applications of 3D technology? I think one of the ones we're most familiar with would be study models, and that's in large part due to OrthoCAD and Invisalign, having the 3D study models available to us to diagnose and treatment plan with. Another area would be just working with the analysis and diagnostics using CBCT, integrating that with 3D models and 3D photographs. The ability to do virtual treatment simulations using the integration of the STL files and the CBCTs in order to determine tooth movement. Really, in the last 10 to 15 years, about the only company that could provide us with that information was SureSmile. If you use their arch wire bending programs, and it was a great way to treat patients. For my demographics, it didn't really fit from a cost perspective, but that was about the only way you could really see what movement of teeth and roots had, or based on the relationship of those structures with the skeletal structures. But the ability to do virtual treatment simulations using this information, I find great value in it, particularly on complicated cases. The option to do 3D printing has been huge in my office. I currently have 3 Formlabs printers and use those on a regular basis. So The biggest application of 3D printing in my office has really come in the realm of aligners, which has been a huge benefit from a return on investment standpoint, as well as the ability to treat patients in a timely manner, i.e. not having to wait 4, 6, 8 weeks of interaction with lab techs and then waiting on the mail and so forth and so on to get the trays to you and then ultimately to the patient. Another option with regard to appliances would be indirect bonding. Been doing a little bit of this. The digital application is a little bit more tough because some of the resins out there aren't quite ideal for it. And then also the ability to do some appliance design using the STL files as they integrate with the CBCT has been important. You can also do some implant planning or TAD planning for orthodontics, looking for the best area of bone, looking for, if the TAD that you're using is going to be too close to a root, if you're placing it between, say, the premolars, is there room there to place it? You could actually print a surgical guide for TAD placement. I'll be honest and say I've never done that, but it's something that, is out there in the literature. And then one of the other and one of the more accepted ways that we've used CBCT over the last 20 years has really been in the realm of orthodontic surgical planning and the ability to simulate that the orthodontic surgery and then print surgical guides as well as cutting guides in preparation for the surgery and for use during the surgery. So those are some of the biggest applications or more common applications of 3D technology in orthodontics. So the biggest practical applications as it relates to intraoral scanning, I currently have the Emerald S scanner in the office. Great scanner, super fast, integrates well with Romexis and the rest of the PlanMecca suite. But the biggest benefit of intraoral scanning in my office anyway has been the ability to produce aligners via whether it's Ortho Studio or ARCAD Labs, Archform, Blue Sky Bio, Sure Smile Ortho, or any number of the U Labs, another one that's out there. Producing aligners in-house is a pretty good return on investment for 3D printing. The ability to save appointments when you're looking at delivery of an appliance. So no longer do I fit bands and take an impression. Now it's a steps appointment and then a delivery appointment. So the ability to save an entire 30-minute deliver appliance appointment in my office is nice. Or sorry, fit bands and impress appointment. Getting to skip that completely and use that appointment time for other things has been huge. The ability to do virtual setups. So again, if you've got a difficult case where you need to think through the treatment mechanics and do a virtual treatment simulation, you can certainly do so. And then I can't imagine doing diagnostics or treatment planning without 3D. And then from a marketing standpoint, just being an impressionist office, maybe that's worth something. So 3D technology in my office, I currently use just regular photos using a Canon SLR. That's not 3D, it's 2D, but it integrates with the 3D. CBCT, I have the PlanMecca Pro Max Mid, the intraoral scanner. I'm using the Emerald S scanner. For diagnostics and treatment planning, I use Romexis and QuickStep Studio. For virtual treatment simulation, I'm using PlanMecca Ortho Studio. For printing models, I've got a Form 2, a Form 3, and a Form 3B. And then for a vacuum former, I'm using the DYFFERENTIATION scan pressure machine. For 3D printing, again, the biggest benefit is the aligners. For indirect bonding, at least at this point, I don't know of a good material out there to do indirect bonding with 3D printing yet, but I know it's in development. Orthodontic surgical splints, dental implant guides. I'll print out some for some of the referring docs that send to me at no charge. I'll just print their implant guides for them. So, way to improve and further that relationship. Clear aligner therapy workflow. In my office, we're doing photos and a clinical exam, and then CBCT. We'll do an intraoral scan as well. Then we would segment and virtually treat the case using Planmeca's Ortho Studio. Then we export that STL file and print the models, and then fabricate the aligners and package those, and then deliver them chairside. But at the core of all of this, at least in my hands, is CBCT. And I can't say strongly enough that I cannot imagine practicing without it now that I've had it. The thought that I would have 3D and access to this technology and then have to go and practice without it would be, I don't know, I really don't know what I would do. I think I would find a way to buy a 3D CBCT machine. Because it's really become that important and that central to what I do as an orthodontist. It really is the framework for everything else involved in diagnostics and treatment planning. The intraoral scan, the facial scanning ability out there, the 4D jaw motion with being able to look at the patient's occlusion and function. You know, all that's great and all of it's wonderful, but at the core of all of that really is the CBCT for diagnostics and treatment planning. So when I talk to other orthodontists about CBCT, these are kind of the top 5 reasons that I hear most often as to why they haven't adopted the technology in their own practice. The first one is, oh, I don't want to, oh, come on. Hang on one sec, let's go back. There we go. The first one is, I don't want to over-radiate my patients. And I think historically, maybe before ultra-low dose, partial rotation, and other technological advancements, maybe you could have made that argument, oh, that we were dosing our patients too much, particularly if we're treating a large population of children. Maybe you could argue that. But now, with radiation doses being what they are, that's really a non-argument in my mind. Number 2, I don't know how to read or interpret a CBCT. I think that's a legitimate argument. I think that's one area that Planmeca is really trying to make headway on, is educating doctors and orthodontists on how to read and interpret CBCTs so that they can use them more effectively. The third one is, I don't want to be liable for all that information. You're liable for all that information, whether or not you take the CBCT, based on simply the availability of the technology in society today. So whether you want to be liable or not, if you miss something that you could have picked up in 3D, just like if an orthopedic surgeon misses something that he could have picked up using a CT scan prior to surgery but didn't and only used 2D, he would be liable for not using 3D because 3D is so prevalent in the hospital system. I would argue that you would be liable as well. The fourth one, I can't afford a CBCT machine. And for an orthodontist that's been out, you know, let's say 15, 20 years, to give me that argument is really laughable. I'll be honest, between the coffee trips and ice cream trips that my kids go on a daily, or well, used to go on a daily or monthly or weekly basis, they probably spend more in eating out and going to Starbucks than I do on the CBCT machine. Essentially, it pays for itself through the diagnostic records fee. So the idea that you can't afford it, I think, is really a non-issue. And I think at the heart, if you're really talking to somebody, they would, you know, at the end of the day, they would probably admit that. And then the last one is, I just don't want to spend the extra time or money doing the education that would be needed, or spending the time looking at the 3D images and going through the scans. And, you know, I get it. That's probably a valid argument. I mean, there is some time involved in treating and diagnosing this way. But, you know, there's also some huge benefits involved by doing so that don't exist to your patients if you don't. And so really the question comes back to you is, how do you want to practice? Do you want to practice at the highest standard of care? Is that what you want to be known for at the end of the day? Like that, you know, you're practicing at the highest standard of care, or do you, he's gotten by with this for the last 20 years. He'll get by with it for the next 10 or 15. For me, it really comes down to, how do you want to practice? How do you want to treat your patients? How would you treat your family members? And for me, I cannot imagine letting somebody treat my family, my children, without having 3D CBCT in practice. And if all you're doing is rendering a pan and a ceph from the CBCT, you should have just saved your money. If you're not really spending the time to learn and to find out how this can affect your treatment planning, you've really wasted your money. So get in there with the education courses to find out how you can better use this technology, because it's there. So those are the top 5 reasons that I find from orthodontists when I talk to them about, oh, why have you not bought CBCT, or maybe you don't want to buy CBCT. These are the reasons why. So some background information and controversy. What we're really talking about then is risk versus benefit. The potential for information overload. How do we process and use this information, manipulate it, and go through it in a timely and efficient manner? The educational deficiencies which exist in our current educational system and where and how that takes place. Sean Carlson's doing some great stuff through OrthoScience with the residents right now, because most residents are, as you know, aren't able to see patients currently. And so he's set up virtual residency programs using Polaris on OrthoScience platform to help continue their education during this crazy time that we're in. Do we provide it through CE? Do we provide it through residency programs? Where is this educational deficiency really resolved? And I think it's going to be a multitude of places, and I think CE, like this one, certainly has a role to play. And the medical legal issues, I've already talked about that, so I'm not going to beat a dead cheetah. So in Nashville, it's illegal to keep a cheetah as a pet. So another fun fact about Nashville, Tennessee, and which is particularly important given our nation's interest in the Tiger King, which, if you haven't seen the Tiger King, wow, that is it is something special. So changing everything, ultra low dose technology is really what did it for me. The ability to image in 3D at a lesser radiation dose than 2D. When I was looking at machines to purchase and which one should I get, and do I want 2D, do I want 3D, it really came down to radiation dose and image quality. And the machines that are looking at full field of view are all relatively similarly priced. Where some of them get you is on the back end. Plan Mecca, they offer the 5-year support, or 5 years part warranty is included in that. No additional fees for software upgrades and all that. So I wasn't getting nickeled and dimed on the back end as I was with some of the other companies that I looked at. So that's one of the other reasons, not only the image quality and the usability of it, but I just didn't get nickeled and dimed, which is nice, because I feel like everybody's trying to nickel and dime us. Oh, it's only $100 extra a month. It's only a registration fee or a monthly subscription fee of $150 or $300. And by the time at the end of the day, you get 10 or 20 of those, and next thing you know, you're spending $2,000 to $4,000 a month in monthly subscription. So it adds up. But ultra low dose technology is really where it's at, because I think there were radiation concerns. If you look at some of the literature, the Cochrane reviews, or the systematic reviews that have been done to look at CBCT dose and whether or not it should be used on all patients, they try to look at this over the course of 15 or 20 years. Well, the CBCT machines that were out 15 years ago, they were dosing it 15, 20 times our current radiation doses. So yeah, maybe that was an issue 20 years ago, but currently, with the ability to use ultra low dose, you can radiate at 15 microsieverts, which is less than 2D, less than a 2D pan in most cases. So I get that the concern was there. My problem with the research that's being done now and comparing this in a systematic review format where you're looking at this over decades, basically, it'd be like the equivalent of doing the same with megapixels or digital cameras versus film. Well, if you look at the resolution of digital cameras 15, 20 years ago compared to what it is now, and then you tried to average that out, you might end up with a 10, 12 megapixel camera, which compared to film, maybe the resolution isn't there. But now, I mean, a lot of us are practicing with 20 and 25 megapixel resolution cameras. And the same can be said with radiation dose. So radiation dose has decreased over the last 10 or 20 years. And to average those out really gives a false reality of where we are as a profession using this information and using this radiation. So with the dose being reduced and having more information, in my mind, it really becomes a non-issue. But if you look at the literature, that's not so much the case. And so the four kind of seminal articles that everybody seems to go back to, or at least three of the four, the point and counterpoint in the AJODO in 2012, the position paper by the AAO in 2010, which was done in conjunction with the American Association of Oral Maxillofacial Radiologists, and then the last one, which would be the history of orthodontic imaging, which was in the centennial edition of the AJODO in 2015. And you can look these up on your own, but the one that I really want to go to is the history of orthodontic imaging from 2015. And it says, this is a quote directly out of the article. It says, the evolution of a new technology, talking about CBCT, took a significant turn. Several CBCT manufacturers with a combination of partial rotation around the patient's head, low settings, and pulse technology where radiation only happens when taking images, created a CBCT scanner that takes a 3D image with less radiation to the patient than a panoramic image. This has resulted in the ideal combination of more information with less radiation, which, by logic and historic perspective, makes the choice obvious. What I don't understand is why we as a profession have not more readily adopted this technology, particularly since this article came out. They basically just summarized my whole presentation for you. It's more information with less radiation, which by logical and historic perspective makes the choice obvious. So in my office, how do I use CBCT? Here's my typical protocol. Every patient is imaged using ultra low dose CBCT, which is a 600 micron voxel size. So it's the radiation dose being around 15 microsieverts. I purposely did not and do not have the 2D cephalometric upgrade, though you could get that if you wanted it. I just don't know why you would. I have the ability to take a 2D pan on my machine. I just never do. Matter of fact, I looked at my number of images taken. I think I'd taken like 4,000 CBCTs, and I'd only taken maybe 30 or 35 panoramic images. And the reason being is, why would I ever image somebody with more radiation to get less information? Even for progress, I'm using a dental only, which is still less radiation in 3D than it would be in a 2D pan. But the only time I've used 2D pan is to look for caries, because on my machine, it's got a caries function under the 2D settings. And it's not even a 2D pan that I'm pulling. It's an extraoral bite wing radiograph that I'm using, and I'm doing that for family and assistants primarily. For adjustable field of view, that's important to be able to vary the field of view based upon need of image size. And then ultra low dose is paramount in orthodontics, giving our patient demographics. And we have seen changes over the last, let's say, 5 to 10 years with our much more emphasis and many more adults seeking orthodontic treatment. I think it's the fastest growing segment in our practices. And, I think maybe ultra low dose isn't as important, even though we should be practicing the ALARA principles when we're thinking about adults. But when we're talking about kids, which most of our practices are probably 60–70% kids, I think ultra low dose is very, very, very important from a radiation exposure standpoint. And so you're getting more information with less radiation. So again, why wouldn't you use it? The other algorithm that's really been beneficial in practice is the CALM algorithm. And what it does, it reduces patient movement after it's happened. So the number one reason for a retake of a radiograph, and this is standard for 2D and 3D, is that is patient movement. So number one reason you're going to retake a lateral ceph, the patient move. Number one reason you're going to retake a pan, patient move. With 3D, because it's taking a little bit longer to acquire that image, you essentially have more opportunity for patient movement. So Plan Mecca really led the charge here in trying to develop an algorithm that would remove that movement from the volume so that it could be used for diagnostic purposes without having to re-image. So not only have they lowered the dose and maintained the image quality with a lower dose, but they've also been able to decrease the number of times we have to retake as a result of patient movement, which is the number one reason you would have to retake. So pretty cool technology there. When we look at 2D versus 3D for orthodontic use, I'm generally taking CBCTs at 3 points in a patient's treatment. And these numbers come from Ludlow's research out of the JADA with average 2D doses. So for initial records in a full field of view, you're looking at about 15 microsieverts if it's 3D, and somewhere between 15 and 30. It could even go upwards to 40 or 45 if you're still using film. Repositioning progress records, doing a limited field of view dental only, that's about a 10 microsievert dose in 3D. And if you're doing 2D and you're doing a 2D pan, again, you're looking at somewhere between 15 and 30 microsieverts on average. And then for final records, I'm doing another full field of view, which again is 15 microsieverts. So my total 3D dose for most patients that are going through treatment from start to finish is about 40 microsieverts. My total 2D dose, if I was to get a ceph and a pan at the beginning and the end, and get a pan for progress repositioning, then I'm at somewhere between 45 and 90. So regardless, we are at less radiation, certainly with a significant increase in the amount of information we have to make diagnostic decisions with and treatment decisions with. So again, it becomes just a no-brainer for me. Why wouldn't we use 3D when it's less radiation and more information? So I would say times, they are changing. Given the high radiation dose associated with 2D radiography, I cannot justify the use of 2D in my practice. With ULD technology, it's become very routine. As a matter of fact, it is the routine to use CBCT. And not only is it viable, what I would say it is recommended from a radiation hygiene perspective. The other thing I will say is it won't be long before 2D radiography is under fire for orthodontic diagnostics and treatment planning, for the simple fact that you are now responsible for over-radiating patients if you're using 2D instead of 3D. So I think the mindset within our profession is in the process of changing and will continue to change towards 3D. It is just a matter of time before we get there. The other question that I always get hit with when I'm talking to doctors about 2D and 3D is, oh, well, does it change the treatment? And I would say it changes the treatment in my practice on every single case. You know, it's really, if you don't know how to use the technology, no, it will never change your treatment plan. If all you're doing is rendering a 2D pan and rendering a 2D ceph from a 3D volume, it absolutely will never, ever, ever change your treatment plan. But if you're looking at CBCT the way I am, if you're looking at CBCT the way many others are, where we're evaluating the alveolar housing, trying to keep the teeth in the bone, looking at airway, looking at, for expansion cases, how much cortical plate is there and where the buccal roots of the first molars are in relation to that, how much tipping needs to happen, what's the molar relationship. I mean, if you're looking at all this stuff, then absolutely it's going to change your treatment plan in every single case. So I think that really, in my mind, has become a null argument, because for somebody that doesn't know how to use the technology, it will not change their treatment plan. For those that have become more familiar with it and use it on a regular basis, I think most of us that do that would argue it absolutely changes our treatment. And you eventually start thinking about cases very differently. You don't hold the ceph and the pan up to the light and then make a treatment decision and guess based upon your experience. You're actually treating, knowing what the patient's individual patient's anatomy is, and making informed treatment decisions with them. So big change for me. And when I think about the comparison between 2D and 3D, one thing I didn't mention in my background is I've almost completed a master's degree in literature and philosophy, and with the emphasis on the philosophy side of it, because I'd intended on becoming a business ethics professor prior to ever going to dental school. And so one of the things that I'm reminded of quite frequently is Plato's allegory of the cave, where you've got the individual from birth has only ever seen the shadows on the wall created by the characters between the flame and themselves. And that's the only interaction that they've had with the world. That is their world as they know it. And then one day, one of the individuals that has only ever seen a shadow is allowed to go out into the real world. And at first, it's painful to them. It's like their eyes hurt. The sun is bright. They don't know how to interact with it because, again, they've only ever interacted with the 2D world. But now they're interacting with the 3D world. The shadow of the tree that was once projected upon the wall is now a 3D version of the tree. And not only is it 3D, but it also has color. The person starts getting excited and they're like, okay, I gotta go back and tell people about this. This is amazing. I can't believe how amazing 3D is. And they go back into the cave to tell their buddies, and their buddies say, you're crazy. You've lost your mind. I don't know where you went for this time period, but we don't listen to crazy people like you. We're happy where we are. We like our 2D images. And I feel like that is a perfect analogy for where we are at orthodontics as a specialty. We've chosen to bury our heads in the sand instead of adopt the new technology that's out there that will really and truly change your practice. So my encouragement to you is really to take the bull by the horns. Get out there and learn as much about 3D as you can. And I applaud you for taking this webinar and other webinars like it during this time where we are off from the office to learn more about this technology, because I think it will only benefit our patients, it will only benefit our practice, and it will only benefit your ability to treat. So another fun fact about Nashville, Tennessee, I did residency at NYU, and as a result of that, spent many Christmases in a Santa Claus hat participating in SantaCon, which is where you kind of bar hop from one bar to the other dressed up as Santa Claus. Well, in Nashville, we take it to the next level. There's a pub called Santa's Pub where Christmas is celebrated all year. Okay, so treatment planning for superior patient care, and this is really the meat of the presentation. It really becomes more about the anatomy of the patient as opposed to historical norms. And I would say without proper diagnostic capability, there's only guessing. So without really knowing what the patient's anatomy is, you're really guessing at coming up with a treatment plan and then enacting that treatment plan. But where you can visualize the alveolar housing when you're treating patients and when your diagnosis and treatment planning is going on, then that really will dictate your treatment options and determine your treatment plan for the individual patient. You're able to look at the anterior alveolar boundary prior to planning any AP movement of the incisors. So in like a 4x extraction case, you're planning on bringing things back and lining things up. You may not have the bone on the lingual surface of the teeth to do so. Or if you've got crowding in the lower and your plan is, I'm going to flare out those lower anterior teeth, and there's no bone on the facial surface of those teeth, you really want to push teeth out into or out of cortical plate. When we look at posterior alveolar boundary and evaluation prior to expansion, so no longer is it, okay, this kid's in crossbite, let's put in a Hyrax or let's put in a quad helix. Now it's, let's evaluate the bone on the buccal of the molars and premolars and determine what appliance is best for this individual patient. So in some patients, it might be a TAD supported expander. In other patients, it might be a hybrid of a TAD and band supported expander. Some patients, they've got plenty of cortical plate and bone buccal of the molar roots. And in those cases, it may be just a simple quad helix or a Hyrax appliance. But essentially, you're using the tools in your toolbox based upon the patient's anatomy, and that's the key. that there are biological limitations which exist that cannot be seen in 2D. And if you don't have that information, how can you choose what's best for your patient? So we've come to the point where we really treat not to the analyses and not to the norms that we're used to treating to, but rather to that patient's individual anatomy. And then the ability to take into consideration airway and OSA and other issues that we tend to come in contact with on a regular basis. I think, again, take the radiation hygiene argument out, which is probably the biggest argument there is. Now you've got all these other reasons. Again, it comes back to what I would say is a no-brainer. So it really is anatomy and not analysis. No longer is 2D enough in a 3D world, and then limitations exist that can only be seen in 2D. And prior to ultra dust technology, we really were focused on looking at the indications for CBCT use in orthodontics. And so myself, Jack Fisher, a good friend of mine, Sunil Kapila, another advisor for OrthoScience, we've all individually, and Jack and I together, said, okay, what are the indications for CBCT use in our profession? And these were some of the ones that we came up with. So it's a no-brainer for any maxillofacial dysmorphology, craniofacial type cases, cases where there was the dentition was some way off, there was an extra tooth or an impacted tooth or something like that. It's a no-brainer. Maxillary transverse issues, expansion cases, dentoalveolar boundaries, AP movement. They're more on the middle of the road, like, oh, do we really need it? Do we not really need it? But in my opinion, yes, you absolutely need it, because how can you treatment plan when you don't know it? The dentoalveolar considerations with regard to implants, bone grafts, skeletal anchorage, and knowing where the best bone is and whether or not there's root proximity to potential TAD or mini plate placement. And then in the very end, just for post-treatment evaluation for surgical outcomes and even for non-surgical outcomes, with the radiation dose being less than 2D, it really becomes very standard of care in my mind that I'm taking post-treatment records to look at what was done as I'm evaluating for wisdom teeth and making sure the patient's healthy. So with regard to 3D analysis, you're looking at no longer the historical norms, you're looking at the individual anatomy. Case Western has worked on developing a 3D analysis, and they have 30 views. And if you want that, you got Sunil Kapila's book there on the left of your screen. That's a great book for an introduction to CBCT and orthodontics. So if you haven't picked that up and you're interested in learning more, that's an amazing book. And it's got a lot of great information in it. Which views do I find particularly important? The NPR view, basically looking at the three planes of space, the axial, the coronal, and the sagittal plane of space, and going through those as I'm going through my case workup and diagnosis. I always pull a lateral ceph, I always pull a PA ceph, I always pull a subdento vertex. I'm always looking at the boundary areas, which again, almost always change or affect my treatment plan in some way. And then any other view you could possibly reposition the volume in to get. So it really becomes unlimited which views could be important. But for most cases, I would say these are the main ones. And here's a good screenshot of some of the ones that I use on a regular basis. And again, when we're looking at indications, clearly craniofacial cases, dysmorphology cases, orthognathic cases were obvious ones to use. For anomalies of dentition, if I'm looking at this pan, I'm saying, this looks like there are no anomalies of dentition. Why does he have this one pulled up? I'm not really seeing anything, maybe some ghosting above that upper right wisdom tooth. Pull up the ceph and I'm saying, okay, everything looks, for the most part, pretty normal, pretty severe overjet. Man, the central incisors are pretty proclined upper and lower. I can tell she's class 2. Okay. But when we look at the NPR view, we're able to really see, oh, hey, there's a supernumerary tooth. There's not only one supernumerary tooth, there's a couple supernumerary teeth. When we look at the 3D rendering of the volume, we're able to even see it in more detail and see what's really going on there. So we can really visualize the patient's individual anatomy and again, make treatment decisions based upon that information. So here's another case. This is a pedo case. The pan was sent to me from a pediatric dentist. I'm looking at it and I'm like, okay, well, those are some crazy position canines. Look how ectopic the upper left lateral incisor is. Well, I don't see a root there, but based upon the orientation of that tooth, yeah, it's probably fine. And yeah, granted, you probably, if you only had 2D, you would use some PAs in order to use the slob rule to determine orientation and where things are and is the root resorbed, but you may or may not be able to see it. But there's certainly some potential for liability when it comes to those lateral incisors. This is the CBCT, a video of me scrolling through those teeth, and you can see how much root structure is missing on those teeth as we scroll through. So that's the upper left lateral incisor, which has quite a bit missing there. Actually, that's the upper left primary lateral, if I'm not mistaken. No, that's the permanent lateral. And then this is the baby canine. Then that is the upper right permanent lateral with a pretty big divot in that tooth as well. And then as we move forward here, hope everybody's eating lunch already, not scared of a little blood, but this is the day that I did the extractions and placed the TAD and removed some bone and activated retraction of the canine away from the central root. So quite a lot going on here, but long story short, you can see where one of those laterals was almost completely gone. The other lateral, very little left of the root, pretty big divot there taken out of it. So this is a case where I feel like CBCT really changed my treatment plan 110% as I ended up substituting canines in this case for the lateral incisors and extracting lateral incisors instead. I feel like if I just had 2D, maybe I would have gotten those other images. Hopefully I would have and realized that there was significant damage to at least one, if not both of these teeth. I would like to hope that that would have shown up. But it absolutely shows up when you use 3D. And so this is her final records. So not a bad result. I'm okay with that. This is another case. Patient comes in and been treatment planned by GP for Invisalign due to a posterior expansion or a posterior constriction of that upper right side. And they ended up coming to my office. We ended up placing 4 TADs. The next couple of images can be a little bit gruesome as we see that the patient wasn't quite taking care of the appliance as well as we would have liked. Some food impacted in there and just some grossness. But you can see that it's being expanded there, and that expansion is taking place skeletally and not dentally. And you see basically how much expansion we've been able to achieve, the diastema that occurs as a result. And then we can look at before and after expansion and the orientation of the buccal roots of the first molars before and after in their relationship with the alveolar housing that they're in. So we were able to achieve minimal tipping of the molars, the buccal cortical plates maintained, and the posterior cross pipe was eliminated. Here's another case of a tooth where we've got some resorption as potentially as a result of traumatic occlusion. And what we can see that there's very little, very thin alveolar housing around those teeth. In addition to that, we can see that the tooth morphology, even the lower incisor, it's about a 1-to-1 crown to root relationship instead of 2-to-1 relationship. So we're able to evaluate not only bone morphology, but tooth morphology as well in order to make treatment decisions. You can see how thin that alveolar housing can get. If you're trying to move teeth around in that, that can become problematic because essentially you're trying to move a tooth through cortical plate, which is very difficult to do and very slow going. And so this is a great case for maybe orthodontics or surgically facilitated orthodontics in order to facilitate that movement to occur. And here you'll get the 3D rendering fly through on what that what all that looks like. You see how ectopic that lateral incisor is and how compared to the normal relationship, how thin that alveolar housing is on the facial surface as well as interproximally. And then consider what tooth movement you're going to do in a case like this. And I think it really has to force us to open our minds to say, okay, maybe I shouldn't just put brackets, wires, and some open coil and some knot tie in and hope for the best. Maybe I need to do more than that to achieve a good, stable result long term. So I think it causes us to think about cases differently than we would have otherwise. The other thing it allows is, and this is what I really get probably most excited about, is the ability to continually improve as a practitioner. And I think the opportunity for 3D superimpositions that you can do in Romexis and then some of the other 3D software or CBCT software that's out there really allows you to look at your cases in all three planes of space and see what effect your treatment mechanics have had. And so you can see the change by fading between post-treatment, which is in gray, and pre-treatment, which is in that orangish color. And you can see what movement had taken place. And in this case, that tooth that was in crossbite was proclined forward, achieving a normal overjet and overbite in this case. So you're able to look back at your work and see what was done in all three planes of space to determine, was this an effective use of treatment mechanics? Is there a better way that I could have done it? So forth and so on. So this is another video. This is actually put together by Sean Carlson, who, those of you that are familiar with CBCT probably know his name pretty well. He's also the founder and CEO of, or co-founder and CEO of OrthoScience. And he put this video together. I think he showed it last year at the AAO, but essentially showing what we're able to look at in all three planes of space and in a 3D rendered file to see what effect growth has had on patients, what effect our treatment mechanics has had on patients. And it's all about embracing this technology, the transparency that it provides us to be honest with ourselves to determine, is what we're doing really working? Is this really beneficial to our patients? Do we need to change the way we treat based on this information? And I would argue chances are the answer to that in your hands, just like it was for me, is yes. You can't read that, but it says there's always a next level. We can always improve. We can always get better. It's just a matter of, are we willing to go along this educational process to do so? And I would say, one of the greatest things about our profession is that ability to continually learn and continually improve our profession and ourselves as doctors in that profession. So let me get here. Ideas over ego. This video won't stop playing. Sorry, guys and gals. So the nice thing is, this is a beautiful video. If you're going to have to watch the whole thing, OrthoScience Polaris. Polaris is the platform that's available to us, and if you haven't checked it out, you really ought to check it out. Polaris. I think it's just search OrthoScience Polaris on Google, and you'll find it. Really, the take-home message for 3D technology and 3D and orthodontics is what you can do with it. It really provides ability to do proper diagnostics and treatment planning. It lets you look at alveolar housing, which you can't otherwise. It lets you prioritize the patient's anatomy over historical norms. It allows you as a doctor to not have to guess anymore. And it allows you to not miss things that you would have otherwise potentially missed. What can you do with extraoral 3D photos? It really comes down to surgical prediction morphing and treatment presentations. There is a coolness factor to that. And then what can you do with intraoral scans? And that's where really the integration of CBCT and STL files or intraoral scans are able to be merged to allow even better diagnostics and treatment planning and virtual setups and so forth and so on. So what we've talked about today is how we can differentiate our practice and how 3D really does change everything, looking at the benefits that we've looked at with regard to CBCT and orthodontics, and how that differentiation and using 3D technology allows us to separate ourselves from the rest of the pack. And then the importance of ULD and its value to orthodontics as a profession and our patients, given our particular patient demographics. The ability to treat to the patient's individual anatomy and not just to analysis, and then the opportunity to continually improve. So Jody, that is the presentation, and I think I hopefully finished up right about on time. And so let's do some Q&A.
All right, thank you very much. Before we dive into Q&A, we did just post the CE survey link in the chat function. So for the 280 of you that are still online, feel free to click on that link so that you can get your CE credits. All right, Q&A. We have about 15, 20 questions here. I think some of these you definitely answered throughout the course of the webinar, but I'll just go ahead and start at the top. Do you prefer 2D cephalometric analysis or 3D analysis?
So currently there's some 3D analyses that are being developed. I think there's some importance in that, not so much for norms and then the ability to treat to those norms. I think the importance is more to the potential to use AI based upon those points to then derive certain images or pull certain images from a CBCT volume. So it's not that, I know I really changed topics on whoever asked that question, but long and short of it is there are 3D norms. There have been some books written on it. Long and short, I think there's some importance in it, but I think more important, what you'll find is, especially once you start using the technology, is that you treat more to the individual patient and not so much to historical norms.
Great. And what 3D software are you using to view images?
So I use primarily Romexis, which is the software program that comes with the CBCT machine. The other program that I'll use occasionally, like the videos that you saw were made using Osiris, which is it's a Mac-based program for DICOM viewing. It's used primarily in medical field, but also has some applications in dentistry as well. Another great program that's out there is Anatomage. It creates some really beautiful images. But at the end of the day, what's important, again, is not so much how pretty an image is, because that's another pushback I'll get from docs is, oh, my 2D pan and my 2D ceph is so much prettier and more crisp than the 3D rendered ceph or the 2D rendered ceph from 3D volume. And I'm like, well, okay, what's more important, that you have a pretty image or you have more diagnostic information? And in my hands, it's more diagnostic information. So there's a bunch of software out there. I primarily use Romexis. And then I will use, I say that, but then I use QuickCeph Studio for my ceph tracing, but it's a rendered ceph that I'm tracing, not a 3D ceph. So I'm not tracing anything in 3D. I'm rendering a 2D ceph, and then I'm tracing that.
Great. And which software do you use to superimpose models in the CBCT image?
Romexis. So Romexis has a superimposition model. It gives you a little bit of help with an algorithm, or you can do it manually, superimpose the 2 time points. I think you could even go more than 2 time points if you wanted to. But yeah, it's primarily Romexis.
Great. And I know that you answered this at one point in your survey because or in the webinar, because you talked about the 3 different images that you're taking. But the question is, are CBCTs part of your standard data intake? There's a lot of controversy on this, and they prefer CBCT all the time, but the colleagues in college do not support this.
Yes, I'll be honest with you. I'm really surprised that is the case. And I think it really comes down to a lack of knowledge and understanding about radiation dose. And it seems crazy because a lot of these rules and regulations were developed by radiologists, but many of the radiologists are simply ill-informed or not informed and not staying current in the literature. And the same goes for orthodontists and you know, the rest of the dental profession as well. Are they staying up to date on what's going on? And I think if you're looking at the machines that are out there currently and the fact that the radiation dose is less than 2D, it becomes a no-brainer, particularly if you have one of those machines. Now, let's say that you bought a machine 10 years ago and your radiation dose is higher, and okay, maybe you need to image 2D before you do 3D. What I would say is you probably need to trade that machine in and buy a new machine anyway, as that machine's probably outdated, both from an image quality point of view as well as from a radiation dose point of view. So you've already written it off on your taxes anyway. It's time to go ahead and upgrade. I feel bad for the doctors that are practicing in areas where they require 2D first, and they're not allowed to even purchase a full field of view scan or CBCT unit, because essentially what by regulation has happened is they're being forced to over-radiate their patients, even though they would prefer to buy a full field of view ULD machine. They're forced to buy a 2D machine, take 2D, and then take 3D. And you talk about a radiation hygiene problem. In my perspective, you're basically over-radiating patients just for the heck of it, not because the technology is not out there, not because the doctor or the physician is not willing to use it, but because you've got people that are ill-informed that are making rules and regulations and directing the way medicine should be practiced. So I think it's unfortunate. I tell everybody that if let's say the state of Tennessee came out and said you cannot take a 3D image until you take 2D, I would go to the New York Times and I would say the State Board of Tennessee is forcing me to over-radiate my patients, and I don't want to do so. So I mean, I feel that strongly about it. 2D has very little to no value when compared to 3D and the amount of information that you can get with it.
Thank you. All right, the next comment, I believe, was in response to the very first DIY case that you presented, and they noted that that number 9 needed endo. And so the question as a follow-up was, is it better to extract and do an implant after ortho treatment is complete?
I think the standard of care would answer yes. You would want to wait until after endo, after ortho is finished, so that we can get the spacing correct prior to the restorative guys getting on there and you know, restoring it. That way everything's symmetric when it's all said and done. So I think the standard of care would say that, and then my own personal preference would be absolutely let ortho finish. And then what took us about a year and a half to 2 years to make that money, you'll make in about 2 weeks or 3 weeks. Well, I guess if you're placing the implant too, let's say you've got what, 4, 6, 9 months of time that you'll make it in. So not quite as a long duration as us, but yeah.
Okay. How do you fabricate the Essex retainer? After scanning, what are the steps?
Cool. That's a whole other webinar. But long and short of it, my workflow from a software point of view, because that's about as deep as I think we'll be able to get at this point, it's intraoral scan, export into MeshMixer, make the STL file manifold, then export out of MeshMixer. In my office, we use Ortho Studio, so I'll import it into Ortho Studio in order to basically cut and close the plane, add the name, any other information to the STL file that I want printed on it so that it's not confused or mixed up in the lab. And at that point, it's printed. From the time it's printed, then post-processed, then the suck down is done or the positive pressure is done, thermoforming, it's cut out, and then put into a retainer case and given to the patient.
All right. Do you think that 3D superimpositions are more accurate than 2D traced superimpositions?
110%. And anybody that has taken boards will and that has used 3D superimpositions will agree with that. It's not a little bit easy. It's very easy to fudge in trace superimpositions where you're looking at the tracing over the X-ray, another tracing over an X-ray. Now we superimpose those tracings. Well, it didn't really say what I thought I wanted it to say. Let me go back, and then you can adjust. Like, that's what worries me when I go to meetings and I see all these superimpositions and I'm saying, hold on, the treatment mechanics don't match with that result. How did that happen? How did they, they're showing they got posterior intrusion using Invisalign, which is even the top Invisalign people out there would say that's ridiculous. It's primarily incisor extrusion that's occurring. Well, you can fudge it a little bit when you're using tracings and you're presenting. When you're using one-to-one, because that's the other thing, there's no tracing error. There's no image magnification error. Like, it's a one-to-one volume to volume that can be superimposed over the stable structures, which we know, and then find out what really happened in the case. So 110% superimpositions in 3D are way more accurate and much less prone to user bias than 2D tracings. Hello?
Sorry, I was on mute.
Okay.
Do you currently use 3D superimpositions on your patients that you finish?
Yes.
Okay. Do you use any measurement analysis for 3D like McNamara and 2D?
Again, that's where it goes back to. There are some 3D analyses that are out there. What I have found, though, is not that they're of no value. There's actually some research out there that shows that if you're using a 3D analysis versus a 2D analysis, and you're comparing cases treated in both formats, you get better scored based on the ABO criteria. You get better scored results when the person used a 3D analysis, tracing analysis. So it's not that it's not important. What it is, it's valuable, but what I've found is it's not as valuable as looking at the patient's individual anatomy. I think that's what ultimately changes things, is you're treating to the patient's anatomy, not to a norm based on patient's race.
Does the CBCT information cause you to do more surgery cases or accept more treatment compromises? The additional anatomy information limits where you can move teeth safely.
That is an amazing question. I don't know who asked that, but they're thinking. And it is yes, and yes. So you definitely have to get a bigger toolbox. So I treatment plan probably many more orthodontic cases than the average orthodontist out there. I treatment plan way more Wilco or PAOO or SFO cases than probably the average practitioner out there. And I accept more less than board quality or board quality results, because my standard is not I'm treating for the board's approval at this point. I'm treating for the patient's longevity and dental health. So there are compromises that I make. Maybe I don't reduce overjet all the way because I don't want to flare the lower incisors and push them outside the cortical plate. Maybe I choose, not to, it's a borderline case extraction, non-extraction, but I'm looking at the buccal and lingual, cortical plates, and I'm saying, oh my goodness, I just don't have much room to move these teeth. Maybe in a BiMAX case, I say, well, you know what, I'm going to leave this patient BiMAX because it's better to leave them BiMAX and to have bone on their teeth than to retract those teeth back into an area where there is no bone. So I think it does cause you to think very differently in the way that you treat cases. You'll do more surgery, you'll do more Wilco and PAOO and SFO, and you'll accept, and the patient will accept, more treatment compromises for the simple fact that you're informing them that, hey, this is where your bone is, and I don't want to violate your biological limits by pushing things out and closing your overjet. I know your overjet bothers you, and if you want that, okay, then we need to look at other options. We need to look at surgically facilitated orthodontics, or we need to consider mandibular advancement or maxillary osteotomy. So I think it changes the conversations that we have with patients, for sure.
All right. Do you feel that the VSP module that Romexis will offer to this country to be a viable use of surgical planning and construction of surgical splints?
So my guess is there aren't very many people in the United States that are aware of that module. And what the question's referring to is most of us, though, are familiar with medical modeling. It's where you can do the 3D treatment planning, orthodontic surgery planning within Romexis. And it's a pretty amazing software. It's very, very, very similar to medical modeling in that you make the cuts, you can print the guides, you can print the splint, and interact with the case the same way that you would with medical modeling. The biggest difference is you don't have somebody as the lab tech that's doing these movements for you. You, the doctor, are getting to manipulate things and determine where things can go and what needs to happen and how the case can be treated. So I think it's an exciting software that's been developed. I think it's in the process of being FDA approved right now. And once it is, I think we'll start to see more orthodontists and oral surgeons using it, if for no other reason than just a cost savings when you compare it to what they're paying for medical modeling and the others out there that are doing it as a service.
And how do your assistants help you with your 3D work, if at all?
So I've got doctors that I work with that do everything themselves, and I've got doctors that essentially have delegated 90+% of it. So in my office, I probably fall somewhere in the middle. There are some cases when I take the CBCT, I'll refer out to a radiologist and have them read it, in addition to myself reading it, because I see something, or it's an adult patient or an at-risk patient, or I just don't have a good feeling about it, so I'll send it off just to like, hey, am I missing something? So there's that side of the workflow with regard to diagnostics and potentially missing something when it comes to radiological finding. Then there's, okay, how do you process these images? I know some doctors that have trained their staff well enough to where they will pull all of the rendered views that the doctor wants on a normal case. And then even to the point where one of the doctors I work with, he's got his staff so well trained that if they're going through it and they recognize that it's an impacted canine or an impacted lower second molar, they'll actually do what I would do, which is manipulate the CBCT volume in order to pull shots of that particular local problem, in addition to all of the other normal images that they would pull, the alveolar housing views, the ceph, the pan, PA ceph, submental vertex, TMJ shots, all of that stuff. So they've got their staff trained well enough to be able to pull those images, and then that does save them some time as they're working through those images. When it comes to STL files, you're really talking, some of that work is tough to train them, or at least in my hands has been tough to train my staff to manipulate an STL file, which will potentially affect a patient's treatment when they're in aligners. So for the most part, the manipulation of an STL file prior to being used in SureSmile or Ortho Studio or RCAT or Archform or ULab all happens on the front end by me. And I could be, some would say I'm a little bit OCD. They're probably right. Some would say I'm a little bit of a control freak. They're probably right. So I'm a little bit more hands-on, and others are a little bit more hands-off. So it really depends on how much you want to invest in your team to help you out. And I've seen some invest a whole lot, and I've seen others just do it themselves, and I probably fall somewhere in the middle.
All right. And what is the youngest age that you recommend CBCT images?
I mean, it depends on the patient. The truth is, if a pediatric dentist is going to take a pan on a patient at, let's say, age 5 or age 6 or age 7, I would much rather take a 3D volume on that patient at less radiation and get considerably more information if they'll send them to me. And some will and some won't. If there's questions about eruption or our teeth present, a lot of them will go ahead and send to me. The downside is they don't get to bill insurance for that pan. I'm not billing insurance anyway. The patient's a little bit out of pocket, but most parents are willing to be out of pocket for their kids, especially if they feel that it's of value. And that's just a patient education issue more than anything.
Yeah, and there's actually a question related to fees. Are you charging a fee for CBCT images? If so, under what circumstances and at what rate?
So in my office, basically I upped my records fee. When I bought the machine, I upped it $100. At the time, I think my records fee was like $250. I think that upped it to like $350. So that basically increased my overall treatment cost. But the difference is when a patient, basically they paid for that image and that record. So even if they don't start treatment with me, I've covered my cost of the machine. And most orthodontists, at least in the US, are starting around 20 cases a month. So if you figure that, then the machine is more than paid for itself. I was actually talking to a good friend of mine, John Price, earlier, and he was saying, I just don't feel right charging more than that to patients because that's not really why I'm taking the image to make money off of this machine. I'm taking the image to do better orthodontics. And he says, I just don't feel right charging patients. Like, I feel the same way. Now, I will charge doctors that refer patients to me to take a CBCT. I'll charge them more. If it's one of my referring doctors, I usually cut them a deal, or they cut their patients a deal. If it's somebody that doesn't refer to me, I've charged as much as $350. So it really depends upon the situation of the case.
All right, and we'll have time for one more question here and we'll wrap it up after that. What resolution setting do you use for your intake CBCT scans?
I do on almost everybody, just because anybody that's been in practice for any length of time knows how difficult training is with regard to staff. And so to throw one more thing that could potentially change based upon a patient, it just complicates things. So I take all of my incoming records on ultra low dose full, which is a 600 micron scan. The radiation dose is about 15 microsieverts, give or take. And it's good enough quality for orthodontic diagnostics. Now, are you going to get a pretty pan out of that volume? Absolutely not. But what do most orthodontists use a pan for? To count the teeth. Anything that would have shown up on joints, chances are that's going to show up at that level anyway, at least enough of a suspect in order to force me to re-image the joint at a higher dose. So I think that answers the question.
Yes,
okay.
I think so.
Yeah.
All right.
That's
and
the
one
same
more.
dose. That's the same dose that I use at the end of treatment as well. Now, mid-treatment, it's an ultra low dose. It's still ultra low dose, but at that point it's a dental only, which is a 10 by 10, and that radiation dose is about 10 microsieverts, but it's at 400 microns. So it's a little bit better resolution in order to look at tips and torques and evaluate alveolar housing and so forth and so on. And then at the end of treatment is another full field of view at 600 microns.
Okay. And we'll end with an interesting one here. What is the difference in care if I send the images out to an outside imaging facility?
So that is another excellent question. That's exactly what I did until I could afford to purchase a CBCT machine myself. And so I found an oral surgeon in town that was willing to work with me, and he charged me, I want to say it was right around $100 a patient. And so at the point that I was referring him, on average, 10 to 15 patients a month, that was my trigger. Because I was like, hey, I'm spending this with him a month. I could make this more convenient to my patients, have better access to the technology, and essentially the machine will pay for itself. So I referred out to an oral surgeon until I got to the point where essentially he was billing me what my banknote would have been.
All right. That concludes today's webinar. Thank you so much for your time, Dr. Burton. Thanks for those of you who joined today and for all the great questions. As a reminder, the CE survey link was posted in the chat along with the AGD code, which was 165. Thank you all and have a great day and a great evening.
Awesome. Thank you all.
Thank you.